Welcome everybody, and thank you for attending this Lunch and Learn session organised in collaboration between the Knowledge and Library Services at NCIC and Boost, the North East and North Cumbria Learning and Improvement Community. My name is Ashley Eaton and I'm from Boost, and today we are joined by Joe Waugh, who is the Clinical Lead First Contact Physiotherapist for Well Up North Primary Care Network in North Northumberland. And he is going to be talking today about the first contact physiotherapy in primary care, the rollout, sustenance, and the future considering the ARMA report. Next slide, please, Joe. These lunch and learns are designed to be a relaxed and informal space for health and social care staff to come together and share their experiences. Next slide, please, Joe. Now, before we kick off, just some very quick protocols. If you can keep your webcams off during the session, we'll give you the opportunity to come back on when we get to the Q&A section. Please mute yourself when you're not speaking. Post any questions in the chat, and as I just said, we will also have some time for questions at the end as well. Listen with respect and please be present. Pass on, share the learning, spread the word about these sessions, and also please be aware that we are recording as well. There will be a link to give feedback posted in the chat, so if you could please complete that, it would be much appreciated. It is just short, just a few questions. I will now hand over to Joe.
Thank you very much. Okay, good afternoon, folks. Thank you for joining us this afternoon. I'm Joe, and as Ashley said, I'm the clinical lead for First Contact Physio in primary care at the Well Up North Primary Care Network in North Northumberland. I've got a bit of a list there about what we might chat through this afternoon, all being well. I'll give you a little bit of an introduction to our primary care network, how we went about recruiting our FCP team, the HE roadmap and how that influenced what we did over the first couple of years. I'll talk about introducing the service to practices and to patients. I'll touch upon the importance of record keeping and our data collection, protocol development and achieving a PGD for the service, and thereafter getting involved with the ICB, the NHS Confederation, and then the ARMA report. I'll hopefully summarise our key learnings and then talk about what some of the ARMA report findings mean to us and facing up to the future challenges. Right, it's not moving on. Okay, so just to give you a quick summary of the primary care network, we're now a we now have 7 member practices, 2 in Berwick-upon-Tweed, the English border town with Scotland, smaller ones in rural small towns in Wooler and Belford, then the large Alnwick Medical Group, which has nearly 20,000 patients, and Greystoke and Gashouse Lane in Morpeth, which is a market town about 20 miles north of Newcastle upon Tyne. We have about 65,000 registered patients, and we employ about 35 staff at the PCN, including the exec team, the exec support staff, and the R staff, including FCPs, pharmacists, pharmacy technicians, mental health practitioners, health and wellbeing coaches, GP link workers, and social prescribers. So I'll give you a little sketch of our timeline. Don't want to get too bogged down in this, aware of the time. So setting up our FCP service and recruiting a workforce has really been a sort of a 3 to 3.5 year project to this point. I was appointed to the role in February 2021, and thereafter we started building our team from about May of that year. By the time we got to the autumn of that year, we had a full team in situ, and importantly, and I think this was really important, bearing in mind a lot of people had not done this role before. People were very much graduated, tapered into a full clinical workload and supported with an awful lot of induction and training along the way. Of course, as I've mentioned, the roadmap to practice, we had that fitted in alongside this, and up to summer 2022 we were working on the stage 1 part of the roadmap, and then up to summer 23 the stage 2 of the roadmap, and there was a little bit of overspill beyond summer 23, but ultimately now we have all of our team through the roadmap to practice. So recruiting the team, everyone on this call is probably aware that there were minimal levels of experience, qualification and postgrad working stipulated in the restrictions. But what we placed an important focus upon was on looking to recruit staff who were really invested in our community, who reflected the population being served, who were in step with local concerns and had a really good knowledge of local referral pathways. Initially, I would say we ultimately failed. Our first drive and attempt at recruiting those kind of people uh, resulted in us not appointing anyone. We interviewed a number but didn't appoint anyone because we felt on those levels we didn't quite get what we were looking for in terms of awareness of what the role was, awareness of our local health challenges, and also awareness of what was required for the roadmap to practice. But a second round of advertising resulted in us ultimately making some excellent appointments, and we've got a team of 5 FCPs. I think one of the key things there I mentioned already was that roadmap to practice. And one of the fundamentals before I even started to recruit what became my team was negotiating protected time to achieve this. It's been really hard for those people who haven't had that protected time at other organisations, but gladly we managed to get good support from our executive who gave us the protected time to ensure that people were able to achieve this work, mostly within their own working time. We were obviously really explicit in the recruitment process that people were going to have to do this roadmap, that it wasn't an optional undertaking, even for those people who'd done the role historically. And gladly, we recruited an excellent GP who was willing to supervise me and then thereafter become an overarching service supervisor. And that relationship has been really key to this service getting up and going. Obviously completed the training course and then providing sensible, realistic timescales thereafter, alongside running a growing clinical service. So staff and patient education became a really important fundamental, a real pillar of what we did in the first 6 to 12 months. We had members of staff and patients, especially in our rural areas, remaining really traditional in their views, wanting to see GPs for their healthcare. Our key message was really illustrating to the practices that we didn't just increase capacity, but we also increased expertise and specialism. Communicating to the care navigation teams who could therefore communicate onwards with the patients that we too could refer for the same investigations and tests and onto secondary care services if required was really important in gaining compliance and getting it to be a service that people were offered appointments with. We obviously aim to make it as simple as possible for the care navigation teams, offering training, inclusion, exclusion criteria, decision trees to shape the telephone conversations with patients, and vitally offering regular updates because, as everyone knows, that part of the workforce experiences quite a lot of churn and turnover. Online advertising and in-practice advertising of the service and engagement with patient participation groups, and also to ensure a consistency of the communication across the patch using nationally available resources to make sure terminology, job titles was translated into something meaningful, palatable to the people using the service. Once we're up and going, obviously there's an important acknowledgement to make that first contact practitioners are exposed to a significant level of clinical risk. So red flag screening and excellent record keeping are really, really important, obviously, to patient safety and good governance. To support this, we worked with our teams internally to develop a bespoke template on System 1. All our practices use System 1, and this Ardens template was then developed thereafter. I've got it on the screen there now, and as you can see, it's become a really important tool for us in ensuring that we not only keep good records, but gather good data to illustrate what we're doing. You can see at the top of the template there, we've got appointment data, including establishing if the patient truly is appropriate for the service. We've got red flag screening up front and center, free text for the notes, but we've got coded diagnosis sections, and also we've got a shared decision-making prompt on there as well to make sure that happens too. We've got appointment outcome data at the bottom, and we've got a variety of options that extend below the bottom of that screen. And obviously, like most things, it required a little bit more work than appears perhaps present on the screen to make sure that we agreed and we used consistent terminology in terms of what we meant by certain outcomes. So after developing the template, ensuring that we get all the team to use it rigorously for every single appointment, which has now just become a habit, we could then start to really understand our service and help shape its development thereafter, help guide our use of resource where we needed more, where we needed less. And then further to that, we also collected data, 200 patient feedback questionnaires and 40 staff feedback questionnaires, which were examined to make sure that what we were delivering was valued, high quality and patient-centered. Here's a little summary of the data we now gather every month. So this is now gathered every month from our template and is presented to all of our practices so they can see exactly what they get from us, full transparency. You'll see at the top left, we've got our patient facing time versus non-patient facing time. We've got our appointment type, you'll see in the bottom left corner there. And as you'll see, nearly 80% of what we're doing is an initial face-to-face first contact appointment. You'll see there are some review contacts, mainly face-to-face, a few on the telephone, but our default model is to work in person all the time, unless the patient would prefer otherwise. You'll see our utilization in the top right. And in this particular recent snapshot, we've only got one appointment unused in an entire month at one of our practices. And that's about where we sit, really. Utilization is outstanding. DNA's fairly low, but slightly variable, certainly sitting probably less than 5% typically. You'll see the referral source in the middle. Now, of course, first contact should really be self-referral for everything. The referred by physiotherapist section there, which has got 9 in the pie chart, that's essentially us booking people back in for a review, maybe to discuss investigation results or to appoint them for an injection. All of our team are indeed injection therapists now. You'll see the appointment outcomes there in the bottom right, and you'll see again that the vast majority of our patients are getting advice about exercise. There's some investigations happening in terms of phlebotomy, there's some referrals to physiotherapy, some referrals onwards into the orthopedic interface service or even other secondary care destinations such as rheumatology, but the vast majority are being safely dealt with in primary care by a first contact physiotherapy, commonly in one appointment. And I think the success of that obviously comes down to the clinician and the quality of the contact, but also excellent care navigation. And the teams that we're involved with have become really good at getting the right cases to us. The patient feedback has also been really positive. This is a little snapshot. Only 1 in over 200 questionnaires rated their overall consultation as less than good. And you'll see this is an example of one clinician's feedback, how people would rate their consultation overall. And most of it sits in the excellent and outstanding bracket. Most of the feedback when people are asked to expand upon it, they appreciate the slightly longer appointment. We work on 20-minute appointments and people feel well listened to and have their concerns validated. In terms of quality improvement and things that we've done to ensure good governance, we've developed some guidelines and protocols. Obviously, as most people realize who are already practicing in first contact environments, we see different patients to what we historically saw in interface services or obviously in secondary care. So we developed a protocol for fragility fractures to enable FCPs to do an awful lot of the workup, sparing the need for GP involvement. So we've got FCPs now, if they're worried about fragility fracture, they'll be requesting the x-rays, potentially thereafter requesting bloods, completing FRAC scores, doing DEXA scan requests, and potentially then processing results thereafter, after suitable training. They would only then go on to get involved with the GP, potentially if medication is then required, albeit we've got independent prescribing pharmacists who can also do that. So this has been an area where we've been further able to develop us saving GP time. Achieving a PGD for the primary care network to enable all our team to inject without requiring PSD has again been a real time saver, not having to pester GPs to get medications added to patients' lists. and then developing a guideline, a comprehensive guideline to support safe, consistent, and really importantly, evidence-based, well-governed MSK injection therapy, which ultimately took a little bit of doing in terms of getting people on board with us, but it's there now. Progressively over time, our service has started to gain a little recognition. Sam Allen, the chief exec of the ICB, came to visit us, and thereafter our service was invited to present at the World Cafe event at St James's Park in Newcastle 2022, where we got a little recognition from Sir Liam Donaldson, who very kindly came to visit us at the tail end of last year to observe a consultation, talk with staff, understand our challenges, and recognise some of the successes. Following that, the NHS Confederation included us as a case study in their impact and success of the Rs Roll scheme report. And then we were invited to make an evidence submission to the ARMA report, which many will be aware has recently been published and launched in Westminster, which I attended in April. To summarise our key learnings, it's pretty basic stuff, but as is often the way, it's the basics, the fundamentals. If you do them ruthlessly well, you don't go too far wrong. So our key learnings would be summarised as prioritising great communication over everything. That's with our colleagues, within our teams, within our practices, and really importantly with our care navigators. Have a really clear purpose and vision about what you wish to deliver. And although adaptability is important, trust yourself. You're generally speaking the expert in your area. Assuming nothing was really important, educating everyone really to the point of explaining exactly what we do, what an appointment would look like, who should be coming to see us, what they should be expecting when they come to meet us. And this has been shown to be a really, really important part of the shared decision-making process. Shared decision-making starts long before the patient ever is in front of us. It starts with selection of the right service. So that's been important. Demonstrating our usefulness, understanding the agendas of those we're working alongside. So yes, there's a particular remit to this role, but also having a little bit of sort of soft-sided intelligence to make sure we mold to what an individual practice really wants from us. We focused, as I mentioned, on recruiting staff who reflect the population, who are truly invested in the community. We haven't regretted this. This has been a real fundamental for us. And collecting and disseminating robust data regularly to build confidence in our service, illustrate what we could do, prove what we could do. We've really felt very strongly that making staff education and the protected time to do it has been an absolute bedrock of what we've done. I would encourage everyone to make the case for it, strive for excellence, prioritise the sustainability of your staff's working week. Your staff, or my staff certainly, pay me back in spades, having invested sincerely in the sustainability of their work, giving them that protected, non-patient facing time. Seeking feedback, however much it may sting occasionally, is vital. Acknowledge it, learn from it. Ensure good governance with protocol and guidelines, and attempt when producing these to gain collaboration. It's rare that anything good happens without that collaboration. And I would encourage you to reach out to other organisations such as the ICB, such as other providers. We've had good links with the guys in North Cumbria. We've got links with the guys in at Northumbria too, and learn from them and each other, and thereafter showcase your work and contribute to progress in your field. Coming to the ARMA report over the last 3 or 4 minutes of this chat, I hope most people dialed in today will have an awareness of this, particularly if you're in this field. MSK health is obviously fundamental to our individual and societal well-being, and in fact affects every aspect of our life. Throughout 2023, ARMA carried out an inquiry into the inequalities in MSK health and related to deprivation. They issued a call for written evidence, and I was one of the people who was interviewed to supply evidence to the report. Key messages from the ARMA report were not terrifically surprising, if we're honest. We see it in front of our eyes, but it's important to have it rubber stamped and therefore give us the impetus to act. People with MSK conditions living in areas of deprivation experience health inequalities. They develop these conditions earlier, they're more likely to have more than one condition, and more likely to be complex. They're more likely to need joint replacement, but less likely to get it. And there's no biological basis for this. This is avoidable. We know that health inequalities are driven by the wider determinants of health: poverty, education, employment, and an environment that deters physical activity and a healthy diet. And we alone can't help entirely in this way, but we can contribute. Two of the key recommendations that we picked up upon is getting closer to and really knowing our community. In primary care, that's the beauty of what we're able to do. And working in a primary care network, I feel particularly well placed. Of course, moving into community spaces is something we're now trying to do, taking services out of the practice, developing shared ownership of services, co-production involving PPGs, and employing people from the local community so patients see themselves reflected in what we're doing. What we're going to do next? Well, our key things are perhaps looking at modifiable risk factors. Being inactive has the biggest impact on a healthy life expectancy, followed by living with obesity, and targeting physical activity, weight, and potentially some links with education are the things that we're really going to try and pick up out of the ARMA report. So from here, we're trying to build relationships and build skills. I've taken part in the Northumberland County Council Joint Strategic Needs Analysis to understand what provisions are out there, our challenges, and our opportunities. In doing this earlier this year, it became clear that one of our major opportunities was to try and look at assisting with a weight management program. 63.4% of adults in Northumberland are classified as overweight or living with obesity. And it's there that we see ourselves as potentially having some further impact. Obesity underpins so many of the long-term health conditions that we're living with. And so we're now looking at how we might, as a First Contact Physio service, develop a multidisciplinary weight management program. We're also linking with local high schools, acknowledging the fact that there's going to be some significant challenges involving our next generation of healthcare users. We're also looking to provide opportunities for staff to become health and wellbeing champions, to support colleagues and disseminate all of this. So we're tapping into expertise locally and nationally. We're making some links with some nutrition and dietetics colleagues in the Midlands who are hopefully going to provide us some training. They've done some research into how non-dietitians and non-nutritionists have conversations with patients around weight, and we're looking to tap into their expertise. Of course, alongside this, we're aiming to continue our in-person offering in all our practices every week, which we do to now, continuing to offer over 1,000 in-person MSK appointments every month. We've also started to host FCP-only student physiotherapy placements, which has been a passion of some of my colleagues to make sure we're educating the next generation in line with current and evolving practice. And simultaneously, we're looking to take advantage of the primary care network model and develop a proactive, front-footed approach, seeking out those who don't access us and consider developing services to tackle our greatest challenges close to home. Novel approaches have been thought of, and we may well embrace them. Visiting food banks has been mentioned of one of our potential opportunities. At the root of everything we've done, I think, from myself, of ourselves collectively as a team and a professional group, to our colleagues who sit around us, to our patients, future service users, our community and wider society, education is the root of everything we've done. Education and communication. And those, I suppose, are the fundamental messages I would leave with you this afternoon. And hopefully, Ashley, I haven't gone on too long.
Not at all, Joe. That was pretty much spot on. So thank you. And it's lovely to hear that they were your key messages, education and communication, because that's something obviously a boost that we
Yeah.
promote so much. So it's great to hear that, Joe. Has anybody got any questions for Joe? Feel free to pop your cameras on, come off mute and ask any, or pop them in the chat. That's absolutely fine as well. So whatever, any questions for Joe? I've got a question, Joe. You said
Okay.
there about getting to know your community. I'm just
Yeah.
wondering kind of what did you do around that? Any sort of
Well,
advice for people?
yeah, so this is a new one. This is work in progress actually, so I'm glad you
Okay.
mentioned that. This has really come out of the back of the ARMA report, which was only published in March, launched formally in April, and then launched online only at the start of this month. So one of our early moves, and the report obviously is focused around MSK health, but it's look, one of the big challenges is in children's musculoskeletal health. So one of our first moves has been to go and meet the head teachers of the local high school. So I reached out to them, discussed the report with them, cited the fact that we've got these looming health challenges that are brewing up in our younger generation,
Hmm.
as
Hmm.
well as the ones we've got currently in our older and aging
Yeah.
population. And so the aim and ambition is to try and work together in school, maybe start to contribute to some of their PSHE education programs,
Hmm. Hmm.
maybe come into some of the PE classes, maybe some of the biology classes,
Hmm. Hmm.
and start to offer some education in there. Furthermore, some of the work cited in ARMA, and this is something we may do, we're starting to reach to the ICB on their weight management
Okay.
work. Ewan Maul has been helpful to us there. He's one of the clinical directors. And we've started with some multidisciplinary meetings to try and establish whether, as part of our integrated neighbourhood team, we can come out and deliver this weight management program, potentially in things like adult learning centres,
Hmm.
potentially in
Hmm.
community centres. And we're also trying to build some relationships with the local food bank, because one of the big things the
Yeah.
ARMA report identifies is the fact that oh, sorry, I lost my train of thought there slightly.
That's
I
okay.
caught sight of the chat in the
Yeah.
corner. But yeah, so I think you probably get the picture.
Brilliant, Joe. No, it's fab. It's great to hear, yeah, what you're doing around that because yeah, co-production is just so important. Actually, yeah, hearing what the community needs
Yeah.
from us as well is massively important. So we've got a question from Grace. So, are any of your FCPs non-medical prescribers?
Hi, Grace. Thanks for the question. No is the one-word answer. It's been given careful consideration, um, and the merits and counter merits have been pondered. Um, we ultimately have decided that we thought there was actually somewhat of an advantage in not being a prescriber with the opiate deprescribing agenda that sits out there. Really, all we would be doing as FCPs would be prescribing analgesia, really, and ultimately. We're trying wherever possible to obviously use potentially non-medical means of moderating people's pain, looking for other solutions. So no is the one-word answer. We've got the PGD for our injection therapy, and on the occasions when we need some medication for a patient, we would send a task to a GP, a duty doctor, or to one of our IP pharmacists.
Brilliant. Thanks, Joe. And then one more question. Is so obviously you've mentioned around the work happening in North Cumbria and Northumberland. Is there any similar work happening in North Tyneside too that you're aware of, Joe?
I'm sure there is. So
Mm.
there's starting, yeah, there is. I mean, essentially speaking, the FCP services are they're kind of put together in different ways across the board by different PCNs. So our PCN took a relatively unique sort of method because we are directly employed by the PCN. We work
Hmm.
for the PCN. A lot of PCNs have subcontracted their FCP work either to private physiotherapy companies, First Contact Primary Care Physiotherapy being one, or to people like Northumbria NHS or North Cumbria NHS, or
Hmm. Hmm.
in collaboration over in South Tyneside and South Northumberland, Northumbria NHS and Connect Health. So yes, I'm sure similar work is going on. I obviously can't comment directly on that.
Brilliant. Grace, did you want to come in with a very quick question? We've only got 1 minute left.
Yeah, it was just very quick. You know, on your template, you've got inappropriate and appropriate referral. We
Yeah,
also have that on our template, but now patients have obviously got a lot more access to their notes. We didn't know how
yeah,
they'd feel about that saying inappropriate referral.
yeah,
Obviously, your data shows where your referral source is from between like GP, physio,
yeah.
so on. What are your thoughts on not having that in?
Yeah, no, it's a good one. That's a good one. To now, I'll be honest, that box is checked incredibly rarely. Okay, so I think it would be a really rare occurrence, but it's a good point. Because like you say, now patients have got access to that. They may well be a little unsettled by the thought that we thought was inappropriate. Um, I don't quite know. I don't quite know really. I'd have to have a little think. What do you think?
We thought about not having it in because of that. Like if patients read
Mm.
inappropriate referral, then they'll be thinking, "Oh, was I seeing the right person actually
Yeah,
for my
undermining
appointment?"
confidence. Yeah,
Yeah.
yeah. No, it's a fair point. It's a fair point. I guess the idea for us, I suppose that was popped there before they were getting access, and it was really to help us feed back to the care management teams really, and just see a bit of a steer on whether we were getting the right cases put in front of us. Truthfully, I think I wouldn't mind removing that now, because I think it's a box that's checked so seldomly, it would probably make little difference to us.
Okay, and just quickly, can I
Yeah,
catch up with you at another point about your, your fragility fracture protocol? We
yeah.
can't currently order DEXAs, and I just wondered how you'd got over that with like radiology protocol, because it sounds very good to be able to do that and take that workload off the GP, but we probably haven't got time to discuss it here because it's probably
Yes.
quite a big topic.
My email's on the presentation, so drop me an email.
That'd be
Yeah.
great. Thank you.
No problem.
Brilliant. Thanks, Grace.
Thank you.
And if you want to make sure you do get a copy of the slides, sometimes the email address doesn't pull through for us on the attendance list. So please just pop your email address in the chat and we'll make sure that you get a copy of the slides as well. So thank you so much, Joe, for coming along. Really do appreciate it. And thank you everybody for attending as well. Just a reminder, we have put a link to be able to give feedback in the chat. We also have a number of lunch and learn sessions coming up, and those are in the chat for you as well. Our next one's on the 10th of July at 1 p.m. And we're going to be joined by Leanne Kirkup and Tracy Garbarino, who are health literacy trainers, and they're going to be talking to us about health literacy awareness. So we hope to see you there. Once again, thank you, Joe, and I hope everyone enjoys the rest of their afternoon. Thank you.
Thanks, Ashley.